I'd like to welcome all the audience to today's webinar talk. I'm Chris VandenBussche. I'll be moderating the session, and today we're very fortunate to have Dr. Ashish Chandra here to speak on the upcoming International System for Reporting Serous Fluid Cytopathology, and hopefully he can give us a good nickname for the system as he talks, so I can learn about that as well. But Dr. Chandra is widely known, internationally acclaimed cytopathologist. He serves as a lead consultant for cytopathology in urological histopathology at St. Thomas's Hospital. He is also a vice president at the International Academy of Cytology and a very active member of the British Association for Cytopathology and the American Society of Cytopathology. He is the deputy editor of the journal Cytopathology, and he has published widely and speaks as a national and international speaker in cytopathology. He was very involved in the Paris system for urinary tract cytology, and now is an editor for this upcoming system for serous fluid nomenclature in cytopathology. So with that, I will turn it over to him, and thank you very much, Dr. Chandra, for being here to speak with us.
Dr. VandenBussche, thank you very much for that kind introduction and the invitation to present the webinar today. Thank you very much also to the audience for logging in from different time zones across the world. I'm very honored to be reaching out to you across from cold but bright afternoon in London. So thank you. One of the very first published announcements in Acta Cytologica came last year in June, and the team of the authors and editors that have worked hard to progress this project has now reached near completion. And here you can see some of the team members and the co-editors of the terminology system. You'll see that there is a whole list of authors, lead authors, and their teams who contributed to the different chapters, including ancillary testing, pathogenesis, cytopreparatory techniques, quality assurance, and our host, Dr. VandenBussche, on a very interesting and challenging aspect of serous fluid cytology, which are peritoneal washing. So in the next 45 minutes or so, I would like to just give you a snapshot of where we are in terms of progressing the terminology system, how it started, and when we could expect it to be ready. I will also demonstrate how to actually apply the diagnostic criteria and how to define the different categories. Of course, before we even get started, there was a lot of discussion and debate around whether we even needed a terminology reporting system for serous fluids. These are very common samples in the cytology laboratory. Most of us have a fairly good idea of how to handle and process these in the laboratory, and in general perform very well in terms of reporting these with good clinical correlation. However, following in the footsteps of the pioneering Dept and the Paris system, it soon became evident that for samples like urine and serous fluids, there were some very important issues that perhaps hadn't really been addressed at a sort of basic scientific level, and these had clinical implications. And therefore, following on from the Paris system, we gave some thought as to whether we could apply the same principles to serous fluid cytology as well. And that meant looking at evidence of adequacy, volume, and cell content of serous fluid cytology specimens, defining what is a true negative sample, and of course the use of the atypia and suspicious categories in this context, which were very loosely defined and just needed a little bit of drilling into to say what we mean when we say atypia and what we mean when we call a sample suspicious for malignancy. It also gave us an opportunity to revisit the value of reporting mesothelioma in cytology. It's been regarded as the domain of histopathologists to make a diagnosis of mesothelioma. However, cytology can play a very important part, and indeed, provided you're using all the right diagnostic ancillary tests, then you could actually arrive at a diagnosis of mesothelioma using the cytology sample, particularly where a pathology sample is not readily available if the patient is still able to have a biopsy or in setting of clinical trials and research. And of course, the very interesting and growing area of peritoneal washing and how to report the presence of epithelial cells in peritoneal washing. So luckily, the terminology system will look very familiar to you. It is something that you're probably already following some variation of in your local practice. It also looks very much like some of the existing terminology systems in Bethesda, Paris, and Milan. But just to spell these out here for you, we have non-diagnostic, negative for malignancy, Typia of undetermined significance, suspicious for malignancy, and then the malignant category, which is divided into primary, i.e. mesothelioma, and secondary, which embraces not just metastatic malignancies such as adenocarcinomas or small cell carcinomas, but also lymphomas, which cannot be regarded as metastatic malignancies, but rather secondary involvement of the body cavity. So, talking first about adequacy and the non-diagnostic category, the sample volume is, of course, a key question for us to address in this terminology system. Is there a recommended volume for fluid samples? And based on a number of studies, but the most outstanding one, in my opinion, coming from Johns Hopkins, Dr. Rupert et al., which suggested that 75 ml was an optimal volume. But of course, it raised the question whether a sample that was less in volume than this should be regarded as somehow inadequate or limited in terms of its diagnostic potential, and we need to explore this further. Also, about what advice we give to clinical teams, the doctors and nurses, about collecting pleural or peritoneal washing or peritoneal fluid samples in the wards from patients, how much volume is necessary, what sort of a container should be used, and of course also the fact that perhaps aliquoting of these specimens is best done at source and not after sending it to the cytology laboratory, because the sample may become compromised for either testing for biochemistry or microbiology if it reaches any of these departments first. So some sort of a central laboratory either splitting these samples early on or best done at the point of connection. In terms of the cellular content, do we have to see mesothelial cells for a serious fluid sample adequate? We do accept the fact that we could just get effusions which are lymphocyte rich, such as in TB or in thymus effusions, or rich in neutrophils, such as in acute bacterial infections, and you may not see any mesothelial cells in these specimens. On the other hand, you could also make a diagnosis of malignancy, where there is a single cell population and the complete absence of mesothelial cells. So therefore, you don't have to have mesothelial cells in order to call a specimen adequate or diagnostic. What's probably more important than the cell content is the cellular preservation. And so a sample could be non-diagnostic in spite of being a very cellular specimen, as we know, of course, from our FNA and other diagnostic cytopathology specimens. And the loss of quality due to either degenerative changes from delay in reaching the laboratory, bacterial overgrowth, technical artifacts, and contaminants can all influence cellular preservation and interpretation of the sample. So if we just look at an example, fairly standard history, 54-year-old male with left-sided pleural effusion, cough, chest pain for 1 week. But macroscopically in the lab, we only received 2 ml of a heavily blood-stained sample from which 1 thin rep and 1 liquid cytostain have been prepared. You don't even need to put this slide under the microscope to know what to expect to see here, which is not very much at all, apart from perhaps live red blood cells. And on the Ginza or liquid preparation again, all you see are red and white blood cells. The sample is non-diagnostic. I would like to make the point here about not actually calling the neutrophils here acute inflammatory cells, because that might send out the wrong message to the clinician, thinking that they're talking about an empyema or an acute inflammatory exudate, whereas these neutrophils are simply part of the peripheral blood. So this is all part of red and white blood cells rather than acute inflammatory exudate. So A sample report in this terminology system should have a starting adequacy statement, a diagnostic category, and a clinical comment where necessary. So a sample report for a non-diagnostic specimen such as this one should be along the lines of evaluation limited by any blood staining, likely non-representative sample. The diagnostic category is non-diagnostic, and repeat sampling is advised with 75 ml volume if possible. So let's look at the next case then and the next diagnostic category. 64-year-old male with liver cirrhosis and ascites, and the lab received 60 ml of straw-colored fluid, from which two cytosins to be prepared, one pack and one laser. Looking at the laser stain preparation first, you can see some beautiful mesothelial cells with the lovely two-tone cytoplasmic staining, pretty borders of the mesothelial cells, and the relatively uniform appearing nuclei. The groups of mesothelial cells are infiltrated by inflammatory cells, including large numbers of neutrophil polymorphs, which seem to be the most dominant population on the screen, but also with scattered lymphocytes and some macrophages. On the back, again, we see the same mesothelial cells with windows or gaps between them, some reactive chromatin, small nucleoli, and infiltration by neutrophils. And here the neutrophils are important because they're not just part of the peripheral blood, but these are actively infiltrating into the mesothelial groups and reflect pathological inflammatory process. So the sample report for such a case might again include those three components. And so negative for malignancy, you would report where you have the normal or expected cell population. These may be in variable numbers depending on which is dominant: lymphocytes, macrophages, epithelial cells, neutrophils, and eosinophils. Dr. VandenBussche has put together this amazing diagram which gives you a snapshot of what you might expect to find in an adequate specimen, which may be either completely benign with mesothelial cells and some inflammatory cells, and then based on what types of cells are present, you could either actually just call these negative or also follow a differential diagnostic pathway of mesothelioma or lymphoma, whereas if you've got, if you take into account the volume and distribution of these cells, with most mesothelial cells going singly or in small groups without any cellular epithelium, small numbers of other inflammatory cells, you would just call this sample negative. If you see some unexpected cellular and non-cellular findings, obviously there is a malignant cell population, you deal with it in a different way, which we will come to later on, but also not to get too baffled when you see some non-cellular components like lymphoma bodies, collagen balls, asbestos, LE bodies, etc. And this does not mean that the sample should be called atypical, and that these could still be called negative for malignant or benign. And so your sample report for a negative for malignant would read something like this: satisfactory for evaluation. In our particular case, it's made up of neutrophils predominantly, with small numbers of mesothelial cells and lymphocytes. Diagnostic category is negative for malignancy, with a comment given that this is a patient with cirrhosis and has ascites. A high proportion of neutrophils are present, and they may represent spontaneous bacterial peritonitis, and correlation with clinical findings may be. Depending on the predominant cell type, you could actually make some clinical comments about eosinophilic effusions, the possible causes of it, or lymphocytic effusions, and also neutrophilic effusions, whether it's empyema or occasionally where there may be a direct contiguous spread of blood carcinoma into the fluid cavity. So those are just two examples of non-diagnostic and negative samples, and some of the thinking that has gone into defining these categories and what cases to put in these categories. Moving on now to the slightly more challenging atypical category, let's start with a case example of a 46-year-old female with a history of breast carcinoma 6 years ago, now presenting with symptoms of cough and poor fluid effusion. We received a moderate volume of sample, 20 mils, four-colored, from which one cytosine and one path have been prepared. And there is cellular degeneration in the sample. You can see macrophages and lymphocytes, but you can also see some larger cells with slightly higher NC ratio, slightly hyperchromatic, or these just degenerate epithelial cells or macrophages. But in the context of clinical history of breast carcinoma, I would certainly be very much more alert and have a lower threshold for perhaps investigating such a sample further, particularly in the face of degenerative changes. And again, on the FAP, similar small numbers of atypical poorly preserved cells are present. They probably represent degenerate mesothelial cells, such as here, but it is difficult to be sure given the poor quality of the sample. And in this scenario, we could actually use the AUS category because we've got occasional poorly preserved cells with nuclear enlargement, mild hyperchromatia, but no obvious chromatin or nuclear membrane abnormalities. If you see those, then of course you would be more suspicious, and perhaps it would be appropriate to put those cases into the suspicious rather than the atypical category. But here we're leaning in favor of cellular degeneration, and therefore we favor that the cell lineage is that of macrophages or mesothelial cells rather than epithelial cells. And so you would want to make a cell block and perform immunochemistry to detecting epithelial cells. And on the cell block, again, there were no obvious epithelial cells seen. Similar degenerative changes were seen. All the immunostains or epithelial markers were negative in this case. And so this sample could be downgraded from being called Atypia initially as a holding diagnostic category while you're waiting for the results of the to negative for malignancy once you're satisfied that the changes were indeed degenerative in nature, and the few cells that you were worried about, which look like they may possibly have been poorly preserved epithelial cells, have not been demonstrated using immunochemistry on the cell block. So this is an uncommonly used diagnostic category in serous effusions. In fact, many experienced cytopathologists don't use this at all. And even of our own group of authors, we had a lot of discussion about whether we could do without the atypical category completely, and that would have been an absolute dream come true for a cytopathologist to have a terminology system which is completely devoid of an atypia category. However, the survey that was carried out by Dr. Dan Curtis and his team reported back to us by over 600 respondents from across the world that they do use the Atypia category separately to the suspicious category, although there was a degree of perhaps an overlap between the Atypia and suspicious categories, but there was a strong willingness for the cytopathology community to include Atypia in this terminology. What seemed to be coming out of that survey also was that there was a two-step sort of thinking process or a thought process that went into these difficult specimens, the atypical and suspicious, where either colleagues were issuing a preliminary report, which was optional, not everybody across the world does that, or you were just putting that case aside and waiting for the immunostains to come back before a final report was issued. So the algorithm in my mind that I thought I was following in my practice and which seemed to fit in with the results of the survey were that typically we are talking about specimens with small numbers of atypical cells. The whole question here is whether they're macrophages, epithelial cells, or epithelial cells. And so we have a differential diagnosis between a benign or a malignant entity, but we are favoring a benign outcome. So our preliminary assessment here might be AUS, whether or not you issue provisional or preliminary report here is optional, but you would go on to do immunochemistry to demonstrate these atypical cells, and if these are demonstrated to be macrophages or mesothelial cells, the final report would be negative for malignancy. If it demonstrates these atypical cells to be epithelial, then you could move it up into at least the suspicious, if not the malignant category. And it would remain atypical if there was no further sample or the sample did not contain the representative cells or the immunochemistry was equivocal. And then you'd be left with a very small proportion of cases that you would sign out as. So here's three examples of cases that were originally thought of to be atypical, and so the provisional report was sent out as being atypia, and a note which described the findings that they were for cellular specimens with a mixed population of cells, but very few cells showed some abnormalities, and in view of perhaps a history, a compelling clinical history, further investigations are being carried out, and you could hold that report and then issue a supplementary report, which would then go on to say that the cell block may be consisted of blood only and should be considered non-representative, and so additional ancillary studies could not be performed. And so here the final report would remain atypia, and we would advise submission of any further samples made. Another example of an AUS report where the provisional report would go out saying atypia for the following reasons. Again, that there's a mixed population, but scattered number of cells showing no degree of abnormality in terms of enlargement, but no hyperchromasia or chromatin abnormality. So clinically, you are influenced by the fact that there is a compelling history, but cytologically you favor these changes being benign and possibly only degenerative. And that if you could follow that up with a supplementary report, if you don't, or you could hold back your provisional report and only issue one without the two-step reporting process. And so in this case, for instance, it turns out that no malignant cells are identified, and so the report is downgraded negative. The comment that no epithelial cells are highlighted with stains, indicating that they were either epithelial cells or macula. And a third example again of AUS, and this is for a peritoneal washing specimen, where some atypical epithelial cells are present with pneumoma bodies, consistent with previous borderline tumor. And so this is provisionally put into the atypical category, whilst perhaps you're still waiting to correlate the findings with the histological specimen. And then after you have a chance to compare the cytology with the histological type of the tumor, then you could, of course, say that this is probably an ovarian findings are compatible with this borderline ovarian tumor. So that's the atypical category, where you're actually favoring a benign diagnosis, but there may be a compelling clinical history or small numbers of cells where you feel uncomfortable just signing out as negative. Moving on then to the suspicious category, here we have an example of a 68-year-old man with pleural fluid, history of lung carcinoma, and we received 30 ml of blood-tinged fluid. And here the abnormal finding is that you've got a three-dimensional group, even though it was the only group on your cytosine, but it was made up of 3 or 4 cells with vacuolated abundant cytoplasm, and also on the back maybe just the occasional degenerate cell, which you were uncertain was a degenerate epithelial cell, but you are a little bit more suspicious than in the atypical category because of the three-dimensionality of this group and because of the abundant vacuolated cytoplasm, that this could be suspicious for malignancy. So here, the algorithm changes slightly because, again, we're talking about small numbers of cells, and this could just be on the initial cytosines or the direct spread, or even on the plot or the cell block that might follow. But morphologically, you're favoring an epithelial or other malignancy. And so your preliminary assessment here, whether or not you issue a report, is that it's suspicious for malignancy. If immunochemistry goes on to confirm the suspicion, then of course you would upgrade the final report to malignant secondary. If, however, there are insufficient representative cells on the cell block or the immunocytochemistry performed on the cell block is equivocal, then your final report would remain as suspicious. And this would only be expected to happen in a small number of cases. So in this case, for instance, the cell block had another group or two of these three-dimensional clusters of epithelial cells, vacuolated cytoplasm, although there is a little bit of nuclear atypia and pleomorphism, your suspicion of malignancy here is much stronger. And once you get your immunostains back for whether PDX1 or whether this is PDX2, depending on what the clinical question is. You've got convincing nuclear positivity to demonstrate that these are indeed epithelial cells. And so you would, in this case, for instance, after getting the immunochemistry positive for TPX1, MAPSNA, you would upgrade it from suspicious category to the malignant secondary category, and then also specify that this is consistent with metastatic lung carcinoma. So although it's not essential that you would have to state what the primary site is, but your immunostains should at least confirm the epithelial nature of the cell in the fusion for it to be put into the malignant category. And then once you've got that and you've got additional material to be able to actually demonstrate what the primary site is, then your report is clinically complete. Of course, in this day and age, simply making a diagnosis in terms of metastatic lung adenocarcinoma may not be enough, because you would still require some residual material for doing your PDL1, ALK, and ROD1, depending on whether you do these by immunochemistry. And of course, then you also need to have sufficient cells to perform any mutation analysis studies, whether it's a full NGS or simply EGFR or a KRAS mutation. And so you might still need a further sample, although this is diagnostic of malignancy. But in order to answer the clinical question for targeted chemotherapy, you might still need to ask for further samples. And so the advice really that follows on from here is that one should be a little bit conservative in the use of our reserve material in the cell block, and that our choice of antibodies and on immunochemistry should be kept to a minimum, so that you are mindful that you might need material for performing molecular tests, and it might run out if you've done a very wide panel initially. So here's the sample report for the suspicious category. This is an example of a 64-year-old female with ascites awaiting a radiological scan to detect the primary site. We will sense 28 ml of hemorrhagic fluid within which a clot is present. And microscopically on the cytospin, there's a mixed population of inflammatory cells, but also some dispersed cells and an occasional group with large PCI and hyperplasia, which is suspicious for malignancy, in this case, an adenocarcinoma, and a clot section and immunostain were to follow. And at this point, again, you have a choice whether or not to actually issue a provisional report, whether your clinicians like receiving provisional reports or they don't. But then if you do put a report out, at least you save yourself a phone call from the clinician saying, what's happened with this case? I haven't seen the report. And then it just saves you the time of having to do all the explaining over the phone, whereas if you put a report out, it is there on the system for the clinician to see, and they know that the matter is in hand and that you're working towards reaching a definitive diagnosis, and in that case, you would probably be prepared to wait another day. And then the supplementary report comes through saying that the clot section contains similar groups of cells, and that morphologically is beginning to look more consistent with adenocarcinoma, and the immunostains are there to back up your diagnosis. So here's another example of a suspicious report. In this case, one of a lymphoid proliferation, which looks suspicious for a lymphoma because of the population of large lymphoid cells in this fluid and in the appropriate clinical setting. Bilateral pleural effusion, 60-year-old man, numerous lymphoid cells, large lymphoid cells also present. And so the provisional report is suspicious for malignancy, high grade, results of flow cytometry to follow. And then in this case, this was confirmed to be a diffuse large B-cell lymphoma, secondarily involving the peritoneal cavity. And so if you really wanted to ask the difference between atypical and suspicious, given that we are talking about small numbers of cells in each of these categories, I would say got at least about 3 or 4 differences, and there are others that I'm sure you could suggest as well. But these are the ones that come to mind most prominently. That in AUS, you only have mild cytological abnormalities, such as nuclear enlargement, mild degree of hyperchromasia, and again in small numbers of cells, only occasional groups. Whereas in the suspicious category, the degree of the cytological and nuclear abnormality is higher. So that these are often three-dimensional groups. So there are some supportive architectural features, and also the nuclear abnormalities in terms of nuclear enlargement, hyperchromasia, and perhaps chromatin, and nuclear membrane abnormalities also start to become evident. So in the atypia category, you're favoring a benign cell type, but you can't confidently exclude epithelial or other malignant cell of origin. Whereas in the suspicious category, you are strongly favoring an epithelial or other malignant cell of origin. So on the immunochemistry, in the atypical category, you're expecting the outcome to be benign, but in a small proportion of cases, this may be suspicious or remain inconclusive as an atypical. The same is the case for suspicious. Most of the time, you're expecting the outcome to be malignant, but a small number will just remain suspicious. So the suggested risk of malignancy in the atypical category, and this is being borne out by recent publications in literature, where there's a very good separation between the atypical and suspicious categories if you follow these diagnostic criteria. Okay, moving on now from the atypical and suspicious categories to another challenging area of mesothelial proliferation. And here again, just to start with an example of a 68-year-old man with a history of occupational exposure to asbestos, unilateral hemorrhagic pleural effusion, 80 ml of blood-stained fluid with a clot, and obviously quite a strong history here, which will make you seriously consider mesothelioma. Mesothelial cells can be very pretty and very bland in their appearance. Here again, you can see a very lovely example of a two-tone cytoplasmic staining, relatively bland appearing nucleus, but with some chromatin abnormality, but the cytoplasmic features remain unchanged, a nice, pretty lace-like border at the periphery. But in a mesothelial, florid mesothelial proliferation, you could find really crowded groups, all of them roughly the same size, or some outlying gigantic groups, but by and large, mulberry clusters of mesothelial cells. The nuclear morphology by itself may not be very pleomorphic from one nucleus to the next. Within the same group, one nucleus is pretty much the same size, with very similar staining characteristics to the one next to it. So it lacks the nuclear pleomorphism, it lacks the forced vaccination of the cytoplasm, and it does retain the mesothelial properties of windows or gaps being present within or between the mesothelial cells. So all of these images are taken from the share file, which have been contributed to by the authors of the terminology system. So you can expect to see some of these in the final publication, hopefully in a few months' time. This is the cell block from this particular case with an obvious mesothelial component to them with prominent nucleoli, gaps or windows between the mesothelial cells, accompanied by a rich lymphocytic interface. The diagnosis of mesothelioma, of course, rests on not only clinical, radiological, and histopathological correlation, but you can use the cytology specimen to its best advantage by doing an appropriate panel of mesothelial markers. And increasingly, I think it's becoming obvious that you need to have at least two, if not three, of these markers in immunochemistry, and ideally also backed up by one of the FISH tests. So Desmin, easily available in most laboratories, showing cytoplasmic staining in reactive mesothelial cells, but which is not in mesothelioma. Epithelial membrane antigen, showing a dense band-like membranous positive staining in mesothelioma. And of course, now FAP1 nuclear staining, which is maintained in the reactive mesothelial cells, but not in mesothelioma. And these two or three panels of antibodies would help resolve most of the diagnostic dilemmas of mesothelial. Obviously, depending on whether an adenocarcinoma is in the differential, I'll come to the minute discussing that scenario. But here again, if you could also do FISH for either P16 deletion or MTA, either demonstrated on immunohistochemistry, but better for actually demonstrating the deletion in mesothelioma by FISH. So for ancillary testing, obviously, if mesothelioma is strongly suspected, then you've got your panel. But in general, it is good practice to perhaps start with a panel of 2 mesothelial, 2 epithelial, and in the appropriate context, perhaps also 1 macrophage marker like CD68. And these will really exclude an adenocarcinoma or just macrophages from your mesothelial proliferation. There are some excellent adenocarcinoma markers available now, like UD4 and clouding, and so these can be used instead of MOC31 and PER84 if they are available to you. Other immunostains are also used, and then of course there are site-specific markers, which I won't read out to you, which you can see here. Bearing in mind, of course, that there are limitations on every marker. You could get WT1 positive carcinomas in the gynae tract, breast, and also some squamous cell carcinomas. And bearing in mind that DARPA3, which was normally marked breast and bladder, could stain up to 50% of the carcinomas. And that's why you always need to do a sensible panel to be able to distinguish adenocarcinoma from mesothelial proliferation. And similarly, for squamous cell carcinoma, particularly when it's poorly differentiated and mesothelioma, because they share cytokeratins and maybe sometimes even calretinin, you do need to use your DP40 or P40 and WT1 in this clinical scenario to distinguish it from mesothelioma. These are some of the pitfalls that you do need to bear in mind in terms of the commonly used markers to separate carcinoma from mesothelioma. So what might sample reports from mesothelial proliferation look like? Obviously, you start off with a comment on the quality and cellularity, that is practical evaluation. Then you would describe the small spherical groups, the dispersed mesothelial cells with mild mesotheliomorphism. Fishes from mesothelioma would, of course, ask for some time to request immunostains on the cell block, or if they're being done on the biopsy, then obviously you'll wait the results of the concurrent biopsy, if that is being reported in your department, even if it's by another colleague. And then if the immunostains are confirmatory, you could upgrade your diagnosis on cytology from primary, consistent with mesothelioma, of course, always with the rider that clinical and radiological correlation potential. If the morphology is classic, but the immunostains are not confirmatory, then you could leave the bottom line as being suspicious for mesothelioma, and of course, advise clinical correlation. And then, if the morphology is not classic and the immunostains are not confirmatory for whatever reason, whether you ran out of cells or there's a technical reason in the interpretation for the immunostains that they're not diagnostic and remain equivocal, then you could simply leave the final bottom line as atypical information and, of course, clinical correlation required. So, the malignant category in serous diffusion diagnosis requires that a recognizable abnormal cell population is present, and a robust diagnosis can be should be made on which clinical management might be made. So there should be enough there to be adequate to guide clinical management based on the morphology alone or morphology supported by immunochemistry. And in that scenario, we believe that even the diagnosis of a mesothelioma can be made safely and confidently in cytology setting. We particularly chose to use secondary and primary rather than primary and metastatic because, as I said, there are metastatic carcinomas, which include adenocarcinoma, small cell, or squamous cell, but then also lymphoma, which would secondarily involve the stool or peritoneal body cavity. Of course, bearing in mind that melanoma and other malignancies, sarcomas, and leukemias will also involve body cavity. So the primary organ site, of course, would need to be investigated in terms of adenocarcinoma. You can't obviously pinpoint the primary if you diagnose a melanoma or a sarcoma. here is next case, 45-year-old female with a cycle, macroscopically 35 ml of blood-stained fluid, and there should be no challenge in this diagnosis. Easy, confident recognition of malignant cells in large numbers, displaying all the architectural and cytological features of an adenocarcinoma, three-dimensional groups with abundant vacuolated cytoplasm, displacing the nuclei, which are hyperchromatic, with really abnormal chromatin pattern and membrane abnormalities, and mixed with a population of inflammatory cells. Here again, tightly cohesive groups with all the hallmarks that we just described for adenocarcinoma. On the cell block, again, if you've got a good sample with a richly cellular cell block, and you've got all the characteristic features of an adenocarcinoma, the significant type of cells being present and glandular formations with central lumina, the diagnosis is confident, it's robust, and it enables clinical management to be guided. And then, of course, depending on whether this is CDF1 or CDF2 or whichever antibody that might be, have not only confirmation of malignancy, but also perhaps the exact site of origin of the tumor based on the common panel that you might be using. So a sample report for malignant secondary would read something like satisfactory for evaluation, spherical groups of tightly cohesive large cells, vacuolated cytoplasm, pleomorphism are present, single cells also present, diagnostic category, malignant secondary, immunostain requested to ascertain the primary and GI tract is the most likely. So coming down to the last couple of slides here then, the diagnostic categories and clinical management into the diffusion can be arrived at by using the morphology on traditional preparations such as cytosine or liquid-based preparations backed up by either spontaneous blocks or induced cell blocks. It would divide them into 5 diagnostic categories. Obviously, the fifth category is split into primary and secondary. If it's a non-diagnostic sample, then of course you would either try and manage the specimen within the laboratory to see if you can improve the quality of the specimen. But if it remains non-diagnostic, then you would have no choice but to ask for a repeat sample. If it is regarded to be negative and is of an adequate volume, then the patient might be discharged or clinical follow-up might be advised. If it is atypical or suspicious, then obviously you've got a two-step hot process there. These are holding categories. These are not truly speaking diagnostic entities, but these are the categories for which you need ancillary testing to establish the diagnosis and, of course, correlation with any biopsy and clinical data. And in the malignant category, where the diagnosis is robust based on morphology, backed up by immunochemistry, and the ancillary testing would be used not just for establishing the primary site, but also perhaps for prognostic and predictive markers as necessary. So we have an amazing paper, a meta-analysis that has recently been published by Dr. Farahani and Dr. Pathology in diagnostic cytopathology, and this has done actually an amazing piece of research, which I wasn't sure that we would have ready in time for the publication of the first edition. So this, has been a real game changer in the sense that we now have the result of a very big meta-analysis, a systematic survey of serous fluid cytology, which has shown how in the past we have been using these diagnostic categories in reporting, with a reported non-diagnostic rate of about 17%, negative rate of about 21%. AUS, as you can see, does in reported literature so far form, it's associated, I beg your pardon, not the incidence, but the risk of malignancy associated with these categories is 66%. What we're hoping to do by application of the terminology system is to actually widen the gap between the atypical and suspicious categories, moving the risk of malignancy of the AUS category closer to negative for malignancy. And in fact, there are some recently published studies. They are one of them, if there is in the reference on the next page, on the next slide, which shows that when you apply these diagnostic criteria, actually the risk of malignancy would become much lower and closer to that of the negative group, whereas the one for suspicious for malignancy is much closer to the malignant category. So thank you all very much for listening. This is the paper that I've just alluded to and shown you one key table from, and also some other studies which have been recently published and shown a good application of diagnostic criteria with a good separation between the atypical and suspicious categories, and with a clinically significant difference between the risk of malignancy between all the diagnostic categories, which should really be the test for a valid terminology. So thank you all for your time. Ready to take any questions.
Thank you. That was wonderful. I invite the audience to have any questions to please type the questions either as a chat or a Q&A to me, and I will read the question to the speaker. Just keep in mind, if you're using the chat window to ask a question, be sure it's a chat directed towards me or to everyone and not specifically to the speaker, because he may not be able to see it. So I'll let the audience have a minute or two to find those windows if they have any questions, and I will read the questions as I see them. In the meantime, I think just a question from me. I know adequacy always seems to be a big issue, and a lot of questions people ask about this, and there's of course limited evidence, and we're gathering evidence. It was interesting to note that in the table you showed from the recent study showing rate of malignancy. It's interesting that the non-diagnostic category's rate of malignancy is very similar to that of the negative for malignancy, even though there's a little bit of a variation of 9%.
Yeah, no, absolutely. That's a great comment there, and it just goes to show that this is in the absence of using the criteria that we've talked about, today. What this reflects the existing practice over the last, 15, 20 years, and that non-diagnostic and negative are associated with a very similar risk of malignancy. Perhaps once we apply more rigid diagnostic criteria, such as that of volume, perhaps the separation between the two categories might be seen in the years to come.
Yeah, we also kind of run into this issue too with, I think it happened with urine cytology, talking about volumes and cells and such, and kind of discussing when something really should be called non-diagnostic versus having some sort of note indicating that a certain finding or low volume might be more related to decreased sensitivity, but not necessarily. It's hard to decide when something should technically become non-diagnostic or inadequate. And I haven't reviewed the final findings of that particular subcommittee, but especially with the papers, I wasn't involved in it, but from Hopkins, where for pleural fluids below 75 mils submitted, had a significantly decreased appearance sensitivity for detecting malignancy. Whether or not that should be a hard cutoff for an inadequate specimen, or simply just below that level, have a note, and then obviously if they're submitting 1 or 2 cc's, it seems like that would be obviously inadequate. But it always seems difficult to know exactly how to call something inadequate versus know that it's sort of a less than optimal.
Absolutely. I think Paris system and all the work that was done in terms of adequacy, volume, and cellularity for urine cytology specimens has actually been one of the pioneering ideas in applying the same principles, if you like, to serous fluid cytology as well. And it hasn't been studied widely in the past, but I think we're already seeing this enthusiasm in terms of the flurry of publications that have come out within the last year, addressing the issues around atypia, addressing the issues around cellular preservation, assessing the issues around volume and cell content and cellular preservation, which are really going to be, in the future. I think we don't have enough data right now to form those kind of hard diagnostic criteria. but it certainly seems to have set the pace and the trend for where research in serous fluid cytology needs to go.
Has there been like a settling in the terminology for just like a nickname for this system? I mean, it's not named after a particular location, which is probably for the best, but how have you sort of, if you tend to just sort of, it's kind of a mouthful. So do you call it like the international system or the serous fluid system, or how are people starting to refer to this?
Well, it's really interesting. I've been trying to come up with a sort of a catchy abbreviation for it. It's proving to be really difficult. Perhaps we should have a little contest to see who could come up with a nice, catchy abbreviation for this. But at the moment, people seem to be just simply referring to it as the international system. And I think the idea was that this has been a very inclusive study, although it is sponsored jointly by the International Academy of Cytology and the American Society for Cytopathology. But the contributors to the terminology system have come from all continents, and we have been very, very inclusive in terms of contributions to the different chapters. So it does have a truly international feel to it. And as you say, yes, there were a number of cities that the terminology system was first presented at or discussed at. But in the end, it seemed like we wanted to keep it something that was for everyone, and we chose international.
Yeah, that's interesting. A contest would certainly be a good way to promote the system. If there was something to win, I think that's an interesting idea, actually. So I don't see any questions. So I do have one final question that I think probably is on everyone's mind, and not that way you can relax and enjoy the rest of your day. Even though hopefully this question doesn't cause you any pressure. I'm sure people are curious as to like a sort of a sense of when what the next steps are for the system. When will people start to see a fascicle or a formal presentation of the system? Is it mostly completed, or what's your sense of that?
Great question. I was going to sort of make a comment about that in a minute, but just to say that all the lead authors and the authors have worked really hard all of last year. All the chapters have now been submitted onto a share file system. The editors are now working their way through them. And so basically we are now reading all the chapters, from cover to cover. We're waiting for, Dr. Dan Curtis has done an amazing job with the images, and we are in touch with the publishers now. We hope in the next few weeks, perhaps, to submit the manuscripts to the publishers, and then the authors will start getting the copies of the proofs back for proofreading, etc. And then hopefully, sometime I expect by the middle of this year, we should be ready to see the book going into production. So yes, I'm hoping it will be sometime in the middle of this year.
Yeah, that's great. It's a nice round year, 2020. So I think the book should be great, and maybe with the Summer Olympics and everything too, keeping with the whole international system. So this is great. Thank you for all your hard work on it. I know the editing of the system is probably the hardest part, because all these different chapters and recommendations have to be aligned. So I think everyone really appreciates all the work done by the editors of the system, and I think it'll be really wonderful when it comes out. So thanks again for speaking for us today. I just want to remind the audience members that this has been recorded, and within a couple of days will be uploaded to the IAC website, so that people will be able to review it if you missed the beginning, or you'd like to re-review certain sections, or if you would like to recommend colleagues to review it who might have to be interested in the system. It'd be a great way for us to get people enthusiastic about it. So thanks again, everybody, and I hope everyone has a good rest of their day.